Hello, everyone, and welcome to this session on Medicare billing, strategies and lessons learned during the COVID-19 pandemic. We are going to cover some of the elements of Medicare billing that have come to fruition more so than ever during this crisis, some of the things that you need to be monitoring during this public health emergency, and some of the things that have been waived as a result of this public health emergency that you will need to pay attention to. So we're going to start with orders management. Orders management being honestly one of the top issues, not only with the public health emergency, but with PDGM in general. It is imperative, as I'm sure the majority of you know and fully understand, that orders be monitored and gotten back from the physician, signed and dated as soon as you possibly can. Timing is absolutely everything. You do have to have the orders back signed and dated before you bill the final claim. You do not have to have them, of course, prior to the wrap. One of the things we have encouraged agencies more so than ever during this public health emergency is to evaluate your current orders practices and ensure that you have a process in place. Ensure that someone is in charge and that someone you know for sure has a plan and is definitely going to carry that plan out and be as efficient at it as possible. We need to make sure that we have evaluated each physician that we get orders from. Now, in light of this public health emergency, as long as your state allows it, CMS has not only approved non-physician practitioners to certify and sign orders for home health during the emergency, it has now become a permanent situation. And so be careful in the sense that if you already had orders from someone other than a non-physician practitioner, an MD, DO, etc., you cannot just take those orders and let a non-physician practitioner sign them. But moving forward, a non-physician practitioner can definitely certify home health patients, refer home health patients, and follow those home health patients, including signing their orders again, as long as your state auspice allows for you to do so. And that was retroactively effective as of March 1st, 2020. And again, that has been made permanent and is not a situation that will simply rely on the public health emergency. So this screen gives you some of the, or the timeline specifically that I wanted to mention that we always suggest agencies at least start with. Many of you are going to discover that you need to have a more stringent timeline than this to get your physicians to cooperate, and that's fine, but it's a place to start if you have not already established an outline of a time frame to use in managing your orders. We're very nervous about agencies laying back on their laurels during this time and not following up with orders during the emergency because they got accelerated payments or because they had a PPP loan and they've got enough cash for right now. And that is the key for right now. How long is that going to last? What are you going to do next? And so you need to be very concerned and very careful about that situation and work diligently to ensure that getting orders back signed from your physicians is continuing. The request for anticipated payment for traditional Medicare, I wanted to discuss some of the do's and don'ts. These, of course, are specific to PDGM and what you should and should not be doing currently with requests for anticipated payment. RAPs do not require OASIS to be transmitted before you file the final claim, before you file the RAP. However, as I was just saying, they are required before you file the final. Even in this emergency, where you've been given a waiver for not having to have the OASIS filed within 30 days, it still has to be filed, the ones that are applicable, before the final claim is filed. RAPs do not require a 5-day timely filing in 2020. However, do understand that as we move through this year, you need to begin preparation for the fact that RAPs will be required to be filed within 5 days once we get to January 1st, 2021. RAPs are paid at 20% regardless of your HIPS code accuracy. So in other words, as long as the HIPS code that is on your RAP is one of the valid 400 and 430 plus options, you will receive the payment 20% of that HIPS code value. RAPs do not require occurrence code 50. Occurrence code 50 we will talk about in a moment with final claims. And it does not require or will not contain an 18-digit treatment authorization code. The 18-digit treatment authorization code was required under the prospective payment system, but that no longer exists. Those codes are no longer calculated. RAPs are required to be in paid status before final claims will process and pay. That has not changed since the prospective payment system. And RAPs are required to have a HIPS code that matches the HIPS code on the final claim. So the final claim, as we're going to discuss in a moment, has some recalculations and accuracy checks done on it when it is processed for payment. But the first step in that reconciliation of final claims is establishing that the HIPS code billed on the final claim matches the HIPS code on the RAP. So it's imperative that you ensure that that occurs. On the final claim, under the PDGM model, you are going to have the exact same requirements that you had under PPS, with just a few exceptions. So first of all, the 18-digit treatment authorization code, as we mentioned, not being required on the RAP, it is not required on the final claims either. In addition to that, occurrence code 50, which again is not required on RAPs, is 100% required on final claims and must be there. Anytime you use an occurrence code on a final claim, you must also use an occurrence date. And the occurrence date with occurrence code 50 is going to equal the MU90 date, or the date the assessment is completed from the OASIS that is going to be tied to that final claim. So it's either going to be the MU90 date from the start of care OASIS, the follow-up or recert OASIS, or a change in condition or other follow-up that you might have completed in the first 30 days. It could also be from a resumption of care that occurred in the first 30 days if you're filing a second 30-day claim. So for OASIS, that it could impact start of care, recert or follow-up OASIS, other follow-up due to a significant change in condition, or a resumption of care due to a hospitalization and resumption that's completed in the prior 30-day period. Occurrence code 61 and 62 are going to be utilized on final claims when you have a situation where the patient has been in a facility with an official admission to that facility and a discharge date from that facility, where the discharge date is within 14 days prior to the beginning of the 30-day payment period that you are billing for. One of the big questions and concerns that has definitely reared its head during PDGM is understanding for sure at what time period this hospitalization can or cannot take place, and you get credit for it. And the answer to that is, when you're filing a final claim for a 30-day payment period, you have to look at what transpired prior to the beginning of that 30-day payment period. So it is critical that we make sure that that is correct and that it is correctly reflected on the claim. So occurrence code 61 is going to be utilized when the patient has been officially admitted into an acute care hospital that does not include observation or emergency room visits or outpatient surgery. It's an official inpatient admission to the acute hospital, again, where the discharge date is within 14 days prior to the beginning of that 30-day period. You will use occurrence code 61 on that claim with the discharge date from that facility. Occurrence code 62 will be utilized when that discharge is from a skilled nursing facility, inpatient rehab, long-term care hospital, or psychiatric facility. Again, where the discharge date is within 14 days prior to the beginning of the 30-day payment period. Keeping in mind that if it is a post-acute facility, again, SNF, LTAC, rehab, or psych, it must be that it is a brand new start of care in order for you to get institutional credit on that claim. So it would only apply, the 62 occurrence code only applies to the first 30-day payment period. So with final claims, you are required to have the OASIS transmitted before you file the final claim. The final claim processing is going to include that they are looking for, using occurrence code 50 and the date that you have provided there with the patient demographics, they are going to go into the OASIS database and look for the OASIS. If it is found, they're going to match several items between the two. If those match, you will clear that edit. There has been a lot of issues going on with that, not specific to the public health emergency, but specific to PDGM and OASIS transmission changes, but most of those have now been resolved. Finals do require that the Medicare MAC reprice your claims, and so basically they go through each phase of PDGM. They determine early versus late. They look at your 61 and 62 codes, and if there is facility information in their system, they validate that. They then get your functional scores from the OASIS, and they use your diagnosis coding, primary diagnosis to establish the clinical grouping, secondary diagnosis to establish any comorbidity adjustments. They calculate that HIPS code, and then that's what you get paid for. And we have learned that different from under the prospective payment system, they actually change and update the HIPS code on the final claim in the direct data entry system to reflect the claim that the HIPS code that they're paying you for, instead of it keeping the HIPS code that you billed and them updating that HIPS code on a separate screen. So do be aware of that if you research those payments and those claims in DDE. You are required to have occurrence code 50 on the claim without question, with the new 90 date again reflected from the OASIS. Finals do not contain that 18-digit treatment authorization code because, again, it does no longer exist. Finals are required to have a HIPS code that matches the RAP, and the 61 and 62 codes need to be there if you would like institutional credit. The LUPA thresholds are much different than they were under the prospective payment system. Under the prospective payment system, we had a LUPA threshold of 5, and that had been the case for the previous 19 years. The LUPA thresholds now vary dramatically in some cases from 30-day payment period to 30-day payment period, and they are based on the 432 case mix groupings. And of course, yours is determined based on which of those 432 case mix groups your patient is in or is calculated to be in. This next screen gives you a little bit of an insight into the data and where that comes from. This is an excerpt from the document that can be found on the CMS website under the PDGM grouper tools. And it has all 432 possible HIPS codes, as you see on the left. and then descriptions of the content of those HIPS codes in the next 3 columns. And then the 4th column on your screen, the one that starts with the number 4, that is the LUPA threshold column. And so for that very first HIPS code line, that patient would have a 4-visit LUPA threshold. So in that first 30-day payment period, or in the 30-day payment period, you would have to provide 4 in-person, in the home, face-to-face visits with the patient. And I say that so specifically because under this current public health emergency, I am fully aware, as we're going to discuss in a few minutes, that you are allowed to do telehealth visits for these patients. The harsh reality of that situation is that while you are allowed to do telehealth visits, you are not allowed to put those telehealth visits on the claim. And if they are not reflected on the claim, they do not count toward your LUPA threshold. So you may provide 10 telehealth visits during a 30-day payment period, but only 3 visits in the home. And if that be the case, if your patient was this first HIPS code patient, you would receive a LUPA payment. So definitely keep that in mind. We have seen a significant spike in LUPA percentages during this emergency. We are beginning to see that back off a little bit, today being May 29th, depending on where you are in the country. But there is still definitely some high LUPA percentages in home health. This next screen takes us a little bit farther into the calculation with examples. This patient was admitted to home health on February 1st, no previous home health episodes. Patient was discharged from an acute hospital on January 31st. The patient has a primary diagnosis of diabetes, E11.9, and no comorbidities that group, and a medium functional score. The first 30-day payment period has a HIPS code 2IB11, early institutional MMTA endocrine, medium functional score, and no comorbidity adjustment, which gives you a case mix weight of 1.4513 with a LUPA threshold of 5. The second 30-day payment period for that same patient has a HIPS code of 3IB11 with timing that is late, an admission source, community, clinical grouping, MMTA, endocrine, functional score medium, and no comorbidity adjustment. So basically the only thing that changed between first 30 days and second was the early versus late, community versus institutional, and we have a LUPA threshold of 3. In this patient example, you would have to provide 5 in-person, face-to-face visits with the patient in the first 30 days, 3 in-person, face-to-face visits with the patient in the second 30 days in order to receive full 30-day payments in each of these 30-day periods. So make sure that you understand you can't just have 8 across 60 days. It has to be 5 in the first 30 days, 3 in the second 30 days, and those are minimums in order to get paid the full 30-day payment. Again, we have seen significant spikes in the LUPA thresholds because you may have been in a 30-day payment period at the end of March where you met the LUPA threshold in the first 30 days and the patient in the second 30 days, you got one visit in and the patient refused to let you come back into their home and you had to do telehealth. That being the case, you would definitely have a LUPA in the second 30 days and the per visit payments would apply. This next screen just basically reiterates the cash flow situation that I'm sure all of you have figured out by now, being almost halfway through the year, which is just hard to believe, beyond imagination, but is reality. The current PPS episode start of care, $4,000 is what the first 30 days or the total 60 days would have been. And in the 60-day PPS episode, when that RAP was filed, we would have received approximately $2,400 under the PPS system. Then you move down to the PDGM model, and the first 30-day payment period you only receive $1,800. That wrap being billed by day 10 would only result in $360. That $1,800 being what the 30-day payment periods were each worth. So the second 30-day wrap would also pay $360. Your first 30-day final claim might not get paid until day 60, which is for the first 30 days, and give you the total amount of money between both wraps and the first final, the total amount of money that you were paid just for a wrap in the prospective payment system. So it's been a really tough as far as cash flow is concerned for many agencies. And then we have this pandemic show up, and it's become even more of a crisis. And so when we talk about cash flow, I still, again, want to make sure that you are monitoring the situation, even if you did get accelerated payments and or the PPP loans, that you are going to continue to fight the fight and keep the billing flowing so that you can continue to cash flow the agency once those funds no longer exist. The number one issue that we have seen with billing home health in this last few months has been the OASIS matching key issue that we discussed a few minutes ago. Making sure that the OASIS matching key, or not the matching key, but the OASIS matching data is matching between the OASIS and the claim, primarily the Medicare beneficiary identifier or Medicare number of the patient. That is typically the number one thing that doesn't match between the two. And if they don't match, you are not going to be able to get paid, because that is one of the key elements that is matched between the claim and the OASIS. Understanding that, you should have less and less of this problem as you have moved farther into 2020, because after January 1st, the OASIS transmission required the new MBI numbers 100%. And so you would not even have been able to transmit the OASIS if it had not had the MBI. And so while you may have a few straggling final claims that have the old Medicare numbers on them, the OASIS would have to have had the MBI. And so the claim is likely the one with the incorrect data if you have a failure in a match there. So I want to take you through some of these 1135 waivers as a result of the current pandemic, and talk about how they can affect your home health revenue cycle and billing. And so the wrap, as we've already discussed, is basically the same as it was under the prospective payment system, except that it has to be filed for every 30-day payment period now. In addition, your wraps under the prospective payment system had a take-back auto cancellation associated with them, and that continues under PDGM. However, under the current public health emergency, CMS has extended that auto cancellation so that it is a longer period of time between the time you file the wrap and the time you have to get the final claim filed. And so without the public health emergency, wraps are taken back within 60 days of the payment date or the beginning of the 30-day payment period, whichever is greater. They have added 90 days to that time period. So basically, from the date your wrap is paid, you will have 150 days to get the final claim filed before the auto cancellation will take place and your wrap money will be recouped. So that was a good thing, a really good thing. The OASIS reporting, they have also waived the 5-day requirement for the completion of the comprehensive assessment. I do understand, however, that you have to have that OASIS in order to get a HIPS code. And so if you delay the completion of the comprehensive assessment and OASIS, you're going to be delaying the billing of your wraps, which might be your only cash flow at this point. So you're going to want to be very cognizant of that. The OASIS transmission requirement to have it transmitted within 30 days has completely been waived. As I said earlier, that does not waive the requirement for you to transmit OASIS. They are just not going to enforce any penalties or calculations because it was not transmitted within 30 days. Your initial assessment, which is the initial assessment that's required just to establish that your patient, what your immediate patient needs are, can be done via telehealth. However, the comprehensive assessment of the patient does still require an in-person visit. Home health aid supervision has been completely waived under the current 1135 waivers, and they are suggesting that you use telehealth to do some level of supervisory visit, but it is absolutely not required. They have also postponed the direct observation requirements for supervisions of aides, and have now said that once the public health emergency has expired, those observations would have to be completed no later than 60 days following the end of the emergency. They are now allowing PT, OT, and speech language pathologist to conduct the initial comprehensive assessment of the patient. And yes, I said OT, occupational therapist, during this emergency, even if nursing is ordered. So if the order comes in for nursing and PT and OT, OT could actually go out, do the initial, and start a care comprehensive assessment of the patient. This is only for the public health emergency. Once the public health emergency has expired, if a nurse is ordered, a nurse has to do the initial and comprehensive assessment of the patient. If it's a nursing only case, then of course therapies would not be able to do the initial assessment. A nurse would have to do it. The quality reporting program has definitely had some waivers occur. The CAHSAH surveys will not be required to be submitted during the quarters that you see on the screen, keeping in mind that Q2 ends on June 30th, and unless there is an extension, an additional extension of these quality reporting relaxation, you will have to begin reporting the CAHSAH surveys in the third quarter. So make sure you realize that's just around the corner. This next one, the value-based purchasing model, they have also waived the requirement for you to submit data directly into the value-based purchasing portal. They have to delay calculations for VBP for this year as well, because of the fact that the CAHSAH surveys that I had just said, they are not requiring to be submitted, are part of the value-based purchasing calculations. So they can't do VBP calculations if they don't have the data. And so the calculations, we are not sure at this point at what point they will reconvene in calculating value-based purchasing, but there is an effort being made to get them to postpone value-based purchasing and only use data from 2021 instead of trying to use the messed up data from 2020. For telehealth purposes, telehealth visits are allowed to meet the face-to-face requirement under home health. Please understand that this is not obviously a requirement at all, and it does not just relate to COVID-19 patients. This is for any patient that is admitted to home health during this public health emergency. But if your patient has been in a facility and is coming from the facility to home health, if you have a valid face-to-face from the facility, you would not need to do this additional face-to-face. This would be for patients you're admitting to home health that has not yet had a face-to-face completed, in which case your patient would be able to receive a face-to-face encounter from the physician while they are in their home. The physician would have to have, and the patient would have to have technology present that has two-way audio-video capability. So in other words, the physician would have to be able to see and hear the patient, and on the opposite of that, the patient would have to be able to see and hear the physician. That being the case, they can conduct a face-to-face encounter in that mode. Understanding that, the home health agency can help in coordinating that encounter. They can be present in the home during that encounter, and they can assist the patient during that encounter. However, any time spent from the home health agency staff in assistance of the face-to-face encounter visit cannot be billed on the home health claim. However, if the agency, the staff member were in the home, let's say to conduct the start of care home health visit and initiate care and begin the comprehensive assessment, if they provide a billable skilled service, home health service to the patient, then you would be able to bill for the visit, just making sure that the time in and time out, the amount of time and units that are reflected on the claim do not include time that that clinician assisted with the face-to-face encounter. So if they were in the home for an hour and 45 minutes was spent on wound care and another home health skill, and 15 minutes was spent assisting the physician and patient under the face-to-face, the visit would be recorded as a 45-minute visit with those 3 units reported on the claim. The initial assessment, as we said a few minutes ago, can be conducted via telehealth. That initial assessment is just to identify immediate care needs of the patient and try to ascertain their eligibility for home health. That can be done via telehealth. In fact, it can be done phone only. It does not have to have a video component to that. But of course, that would not be a billable visit. But the comprehensive assessment does have to be done in an in-person visit. Also keep in mind that when conducting ongoing telehealth visits, meaning after the start of care, those telehealth visits must be recorded in the care plan as telehealth visits. They cannot be recorded in a normal home health plan of care as frequency and duration and goals and all that, assuming and documenting that nurses are going to be in the presence of the patient conducting a physical visit, and then you just decide that you're going to do a telehealth visit instead. They have to be written as telehealth visits in the actual orders. So make sure you're not substituting without a doctor's order to do so. There are no billing codes for telehealth visits ongoing because you cannot bill for those visits. I think I've said that now 3 times, so hopefully that has penetrated. As far as telehealth is concerned, outside of the public health emergency, there are very stringent HIPAA compliant regulations. So stringent, in fact, that some of the telehealth software vendors, or I should say audio video software vendors, are not allowed under the Medicare benefit. But this being the case with the emergency, they have waived the HIPAA compliance factor for telehealth only, which means that the softwares, and one of the ones they used in their example or their explanation was Skype. Skype is not typically HIPAA compliant. However, you are allowed to use the Skype software during this public health emergency to conduct telehealth visits, and you would not be held to any penalties, etc., because of that. Once the public health emergency has been declared ended or expired, you would have to be 100% HIPAA compliant from that point forward with any telehealth visits that are completed. Another element that directly impacts home health agencies during this public health emergency is the homebound status relaxing. And it's not really a relaxing, it's really a more definitive clarification. But patients during this time that are 65 years or older that are eligible for Medicare all fall into the category of being highly susceptible of having or being able to easily contract COVID-19, and it to be a significant impact on their health if they were to contract COVID-19. So they basically have been warned to stay at home and to isolate. And because of that, they are going to meet the portion of the homebound status criteria that says it's medically contraindicated for the patient to leave home. And because of that, those patients are going to need or going to meet the homebound status criteria. You will not get a denial for homebound status during this public health emergency if the charts were to be medically reviewed, as long as that patient is in the elderly age bracket, qualifies for Medicare, etc. They're going to be considered medically contraindicated to leave home and going to be fluid with meeting the homebound status criteria. From a reimbursement standpoint, really good news from this public health emergency. The 2% sequestration deduction from your payments has been completely halted, with all dates of service from May 1st, 2020 through December 31st, 2020. The screen says December 1st, but it is December 31st, 2020. So through the end of the year. And so any claim that has a visit of December 31st or prior through May 1st, you will not receive a sequestration deduction on those claims. Non-physician practitioners are now allowed, as I said earlier, to sign orders and to certify home health patients as long as your state auspice allows for that to be the case. As I was saying earlier, CMS made this a situation to be true during the public health emergency, and then they sent out a interim final rule toward the end of April. That did make this a permanent implementation for home health. So hopefully, if your state has not already permitted for this to occur, it will be, that will be true for your state very soon, because again, CMS has made this permanent, and I just cannot fathom that there will be states out there that will not allow Medicare, or will not allow home health agencies to be in full compliance or be able to take advantage of this full release of restriction by CMS. With those non-physician practitioners, as I said earlier, they can certify the home health patient, refer the home health patient, sign all the orders for home health patients, making sure that you adhere to the specific requirements you always have when it comes to any physician. For billing purposes, they are also required to be in PACOS, and non-physician practitioners do register in PACOS. If they are not registered in PACOS, your claims will deny. So make sure that you are checking to ensure that they are in PACOS. As far as Targeted Probe and Educate is concerned, it is currently on hold. Any claims that you had sent the chart in for review, if you were under Targeted Probe and Educate, as of the date, it was the middle of March when they ceased Targeted Probe and Educate, they were going to review those charts and return the payment. If, however, they had requested the charts, but you had not yet submitted the chart to be reviewed, they should have released those claims to be paid. Once the public health emergency is over, they will resume Targeted Probe and Educate, and any agencies that had received the letter, our understanding is they will continue in that same realm, and additional charts will be requested, and they will continue with that review. Fraud investigations were not to cease, even though Targeted Probe and Educate did. Which basically means that for purposes of the recovery auditors, the UPIC auditors, and the OIG auditors, if you were under any of those reviews, they likely did not cease. The review choice demonstration, currently active in Ohio, Illinois, and Texas, set to begin in Florida, North Carolina on May 4th, has been extended for Florida and North Carolina. Ohio, Illinois, and Texas are still under the review choice demonstration, and the only relaxing as far as the public health emergency is concerned for them is that if they were under pre-claim review, they have been given the opportunity to not participate in pre-claim review during this time. However, they have also been told that after the public health emergency has expired, every claim that they billed during this time that they did not do pre-claim review on, it will be subject to 100% ADR reviews. So all of our clients that are in those states are going to continue PCR so as not to be subject to ADRs after this is over. As far as diagnosis coding is concerned, not only during this emergency, but ongoing, permanently, there has been a diagnosis code put into the official ICD-10-CM code guidelines, U07.1. U07.1 is COVID-19. U072.2 can be found on the World Health Organization website, and it is an ICD-10 code. So there is a difference between ICD-10 and ICD-10-CM. The United States of America uses ICD-10-CM. U07.2 is not in the ICD-10-CM data set and therefore, or code set, so therefore you cannot use it in the United States. So U07.1 is the only COVID-19 diagnosis currently in the code book. As of April 1st of 2020, it has been included in the grouping model for PDGM. As of April 6th, the grouper was updated at CMS and the Medicare Max for claims processing, so COVID-19 can be used as a primary diagnosis on a home health patient. It can also be used as a secondary diagnosis on home health patients, and if used as a secondary diagnosis, it can qualify for a low comorbidity adjustment. So it is fully up and running and is being used, and we have experienced agencies using those codes, so they are there. You need to ensure that your EMR has included that code and is active and running for you. The advanced and accelerated payments, these are the payments that you could request from your Medicare MAC. You had to go through an application process, and they had calculated what the maximum they would allow you to receive in the element of advanced or accelerated payments. They calculated using your last year's revenue and cash payments what would typically be 3 months of revenue or Medicare payments for your agency. And so in this application process, you could request the maximum that CMS had calculated for you, or you could request a lesser amount. Once you had completed that request, they would advance you the amount either that, again, that you had requested, the maximum they had calculated, or a lesser amount. And then this is the kicker. Within 120 days after you had received that distribution, they will begin recouping that money with 100% Medicare withholding on your Medicare payments as you process claims. And so as you are doing the billing 4 months after you receive that money, they're going to recoup all of that money that they advanced you through your Medicare billing. And so this is one of the reasons why I have such significant concerns with agencies that may be laying back a little bit and not freaking out too much about orders and about keeping the billing going, because in 4 months from the time you receive those funds, which was back at the end of March for some of you, which means July is when it's coming, they're going to start recouping that money. Are you at that point going to have enough billing to not only pay Medicare back, but to keep your agency flowing? So I think it's really, really critical to ensure that if you did receive those monies, that you are fully prepared with the amount of billing that you will have to pay that back, plus be able to cash flow your organization. That top statement in red says that this has been currently suspended and no additional funds will be distributed, and that is true. That was effective the last week of April. They have extended the cost report timeframes in which you have to get your Medicare cost reports filed. If your year end was October 31st or November 30th, you have until June 30th of this year. If it was a December 31st year end, you have till July 31st. We have not heard any exception to that. So as of today, May 29th, you have 1 month. If you were October, November, 2 months if you were a December month end. These are some resources that will take you to many of the elements that we have discussed today, specific to COVID-19, the elements that include frequently asked questions, as well as some blog articles from my website, etc. And there are tons more, but these are ones that are specific to the CARES Act Relief Fund and waivers that we have discussed today that could impact your Medicare billing. If there are any questions that you have as a result of this presentation today, please do not hesitate to email me at the email address you see on the screen. You can also email CAHSAH and they will forward the question to me for response. I want to thank you all for participating today. I want to thank the CAHSAH for asking me to do this presentation for you. I hope that I have given you some insight and information into some of the billing issues that are related not only to COVID-19 and the pandemic, but to the Medicare PDGM model as well. Thank you again, and I hope to see you at the CAHSAH Annual Conference.